In this video, we are going to put a center line in the right internal jugular vein under the ultrasound guidance. Patient is under GA with head turned to the left side, neck is painted and prepared with antiseptic solution and draped with a sterile whole towel. High frequency linear array probe is covered in a sterile sheath. As we move the probe from medial to lateral, trachea is seen in the midline covered with hyoid muscles. Laterally, under the belly of sternocleidomastoid is a round pulsatile carotid artery. Lateral to the artery is a non-pulsatile compressible jugular vein. Keeping the IJV at the center of the screen, the cannulating needle is inserted at 60 to 80 degree angle at the center of the probe through the skin, subcutaneous tissue and the muscle belly. Needle tip now indents onto the anterior wall of the jugular vein. Do not press the probe too hard as it may obliterate the venous lumen. With fine controlled movement of the hand, the needle is inserted through the anterior venous wall into the venous lumen. The echogenic tip of the needle can be seen in the center of the venous lumen. Move the probe a bit distally if you are unable to see the tip of the needle as we are viewing in short axis. Dip the needle down and aspirate with a 2 ml syringe to confirm free flow of venous blood. Expect a free flow of blood into the syringe if you are in the IJV. Now disconnect the syringe and advance the Seldinger's J-tip wire through the cannula into the vein. Monitor the ECG for ectopics as the wire may enter the right atria. If this happens, withdraw the wire by a few centimeters. Although ectopics do confirm that the wire is in the SVC and not in the subclavian vein. Now remove the cannulating needle over the wire and introduce the dilator over the guide wire. Use a 11 number scalpel blade with sharper end upwards or laterally to make a small nick on the skin at the puncture site. Now advance the dilator over the wire to dilate the trajectory of the wire. A pop may be felt as the dilator goes across the neck fascia. Now remove the dilator and give pressure at the puncture site to prevent oozing of blood. Introduce the central venous catheter over the distal end of the guide wire and feed the wire into the central venous catheter. The distal end of the wire exits through the widest of the 3 ports of the central venous catheter. Hold the wire at all the times. Once the CVC is all the way into the neck, remove the J-wire. Now aspirate all the 3 ports for blood very gently and flush with saline. The aspiration should be gentle so as to avoid the blood coming all the way to the 3-way connector, as it is difficult to completely flush it and the blood in the connector then becomes a source of infection. Once all the 3 ports are flush with saline, we can once again confirm the position of the central venous catheter in the jugular venous lumen by viewing the sono image in both short axis and long axis. In short axis view, we can see the entry point of the central venous catheter causing tenting of the anterior wall of the internal jugular vein. In the long axis view, we can see the central venous catheter entering the anterior venous wall and the lumen of the IJV, with a pulsatile carotid artery running below it. The central venous catheter is then secured on the neck with 3-point fixation with 3,0-ethylon suture material and a curved needle. Some people may prefer a straight needle with linen. Use 3 square knots for maximum security of each suture site. Make sure to take wide bites of the skin to prevent excessive tension on the skin. Look for the external jugular vein during suturing to avoid a needle puncture into it. The placement of the central venous catheter in the internal jugular vein can be finally confirmed by taking a chest and neck X-ray or even by taking a fluoroscopic shoot by a C-arm in the operation theatre. Apply the chlorhexidine impregnated gel pad antiseptic dressing over the puncture site at the end of the procedure.